Hello, everybody, and a very good evening to you, friends. It is time for that place where you are supposed to be every Tuesday evening at this time, 5 o'clock on the Gulf Coast, which means 6 o'clock on the east, four in the mountains, and three on the west. It's time for Fertility with Fink and Friends. I am Fink, you are friends, and it is great to see everybody here this evening. Thanks so much for joining me. This is the time where we get together and can talk about all those things that are important to us, things about, oh gosh, feelings, things about having families, making families, things about being pregnant, things about women's health, all that is on your mind tonight. Um, let's see, we've got a couple of different feeds going on here as usual. We've got some Facebook, a couple of different Facebooks. We've got New Life Fertility and MCRM, the Missouri Center for Reproductive Medicine. We've got LinkedIn, we've got YouTube, we have LinkedIn and YouTube. I think what did I forget? I think I got them all there. I'm a fertility gynecologist here at New Life Fertility in Pensacola, Florida. We have offices also in Mobile, Alabama, and in Panama City. And I also work with the fine folks at the Missouri Center for Reproductive Medicine in Tulsa, Oklahoma, and in St. Louis, Missouri. So wherever you are, we can talk to you any place, anytime, live and in person, or via telehealth. The world is a wonderful place now, and it makes those things all very, very easy. I've got my Instagram feed right here, and that's Randy Fink MD. If you don't follow me, please do. I would appreciate that. We have New Life Fertility's Instagram right here, and I am taking all of your questions this evening. Meanwhile, let's say hi to all our friends who have joined. Hi, Angela. You are first, number one. You are my number one tonight. Thank you for being here, as always. Great to see you. Christy O'Hearn is here. Over on the New Life side, we've got Sheila, we have Elena, we've got the Bama gal and husband in Mobile, Alabama. That's my beautiful mother. Thank you, Mom, for being here, and Dad. Sarah is here, and Elena is here and says good evening, and a very happy good evening to you. I hope your 4th of July was a great time. It was wonderful to celebrate a holiday, to have a little extra time off. Hopefully you got a little extra time off, as I did. Was off on Friday, and I went to Gulf Shores, Alabama, and celebrated the 4th of July with family there. And it was just wonderful to be amongst family, and wonderful to see the fireworks, and wonderful to enjoy really the great outdoors, and just really feel proud to be an American, and frankly very happy to enjoy a nice weekend outside. You know, our thoughts always go to those who are suffering with some hard weather, and so the heat, it's certainly a thing here on the Gulf Coast, but in the Midwest, with my colleagues in Oklahoma and in Missouri, are really suffering from that heat dome. In New England, folks are having floods, places are having fires. It's kind of a crazy world out there right now, weather-wise. Politically as well, but we try not to talk too much about that, but just to say, you know what, we're happy to be here and able to celebrate the birth of our nation all together here. And so I hope your 4th of July was meaningful, and that it was a good time really had by all. Midgie is also here tonight, and I can see there are some people on the Facebook side, but I can't tell who you are, so feel free to shout out your name and I'll shout right back at you. I had a question this evening come from Mary May, and Mary May asked, tell me a little bit about premature ovarian insufficiency. So POI, premature ovarian insufficiency, is something that we used to call premature ovarian failure. And that has such a punitive sound to it, doesn't it? It's a failure. It's something that's bad. Premature ovarian insufficiency is also kind of the cause of what we know of as premature menopause. And basically what happens there is that for some reason, the number of eggs in the ovaries diminishes rapidly so that menopause ensues prior to the age of 35. Technically, the definition is the age of 35. Now, do you still have that? I would say if you're 37 and you're dealing with the same process, that still is premature. The average age for menopause in the United States is 51.4. So between, almost 51 and a half. Menopause happens when the eggs are all gone. And in the absence of those eggs, the estrogen level starts to drop because the estrogen is made in the cells that surround the eggs and the ovaries. So once they're gone, there's no more estrogen. When this happens to a younger person, it is something that is, can potentially be devastating. And it often comes to our attention in the fertility world because people are trying unsuccessfully to have babies. Maybe they've been told that they have PCOS, that they have polycystic ovarian syndrome because they don't get a period. And that's one of the things that kind of goes along with polycystic ovaries is that people don't ovulate, so they don't get a period. And it may be that their doctor told them, oh, I think it's just because you have PCOS. And then they come to us thinking, well, what can I do about this PCOS so that I can get pregnant? But we come to find that they have a menopausal level of hormones and an egg count that is really no longer detectable. And that is a very, very frustrating problem. What causes it? Well, in most cases, it's caused by things that we will never be able to identify. But there are some scenarios when we can figure out what the problem was. One of those problems can be if you are what is known as a carrier for Fragile X. Fragile X is the most common form of what we know of as a sex-linked mental retardation. And that term is also sort of falling out of favor, but as a sex-linked phenomenon, it is not Down syndrome, which is trisomy 21. It is something that typically happens just in boys, in male offspring, and that's a Fragile X syndrome is what it's called. Female carriers of Fragile X are more likely to end up with premature ovarian insufficiency or ovarian failure. Why might that be? Well, because, think about it evolutionarily. If you have an increased probability of producing an offspring that is going to have a lifelong disability with permanent special needs, it may be that your body has programmed itself to not procreate in that scenario so that you're not adding that to the gene pool and to your responsibility in life. Now, as we know, the uterus does not age at the same rate that the ovaries do. So if you were to say use a donor egg and create an embryo with partner sperm, it is very straightforward to take that donor embryo, that embryo that came from the donor egg, and place it back inside your uterus. And you can carry a pregnancy. You can deliver that baby. You can do everything else completely normally because we can give you the hormones that you need. The problem is not the uterus, and the problem is not carrying the pregnancy. The problem is in the eggs themselves, which arise from the ovaries. So that's the usual solution to premature ovarian insufficiency. It's donor egg. Now, there are some folks who are doing things with the medication sirolimus, also known as rapamycin, that may have the ability to try to reverse that process, but it is still very, very, very much experimental. So in general, I would tell folks who came in with this particular malady that doing donor egg is a downhill ski. Now, it's a hard thing to hear, and it's a hard decision to make to proceed with using a donor egg to make your baby. But it is definitely an uphill climb, if not otherwise potentially impossible, to use your own egg in that scenario. So there is a question, what do those levels look like? That comes from Brittany over there on the Facebook side. And hi, Kelly Lee. Nice to see you here this evening as well. Brittany asks, what do those levels look like? Well, so the two things that we really look for are first an FSH level that is very high. So usually it's going to be around 30, 40, 50, or anywhere above that. FSH stands for follicle stimulating hormone. And that is the long-term measure of your body's estrogen supply. So in the menopause, estrogen level goes down, FSH level goes up. So the higher that FSH level is, the lower your estrogen is. So when the body senses that the estrogen level is low, it cranks out more of this FSH hormone that comes from your pituitary gland at the base of your brain, because that hormone is trying to get the ovaries to produce more estrogen by making more eggs, by stimulating those follicles. And so that's how that works. The higher your estrogen level is, the lower your FSH level would be. So for example, if you are taking a birth control pill, you're getting a lot of estrogen, right? You're taking birth control, lots of estrogen is happening there. Your FSH level is going to be suppressed. It's going to be very, very low. So in the menopause, FSH goes way up. And the other thing that we look at there is the AMH hormone, the anti-Mullerian hormone. So remember, we've talked about this before, that those little cells that make estrogen surround each egg. In addition to making the estrogen, though, they also secrete this hormone called anti-Mullerian hormone, or AMH. So the more eggs you have, the more AMH you make. And the more AMH you make, or the more eggs you have, the more of these cells you have. And the more of these cells you have, the more AMH you make. So we can measure that amount of hormone in your blood and can see really where you fall relative to other people who are your age. When that number appears as less than 0.08, that is what we consider an undetectable level of AMH, and that is consistent with, it is not necessarily consistent with menopause, but it certainly is a finding that we would see in someone with premature ovarian insufficiency. Now, we do see folks who have low AMH levels, which is what we call diminished ovarian reserve. And that's not the same thing as premature ovarian insufficiency. This POF, or POI, as they call it now, means that basically the ovaries are kind of done doing their things. Now, here's an interesting phenomenon. Younger people with what used to be known as premature ovarian failure can still sort of flip in and out sometimes of this condition, that there still may be some eggs in the ovaries that can be turned on. So I can think of two people in particular, both of whom were patients of mine in Miami, who ended up who had a diagnosis of premature ovarian insufficiency or premature ovarian failure. They were both young women in their late 20s, early 30s. I think the first one I saw in her mid 20s, who were menopausal. Right. And that was because of this condition. And in both of those cases, we couldn't really figure out what the issue was. By the way, I said, what causes this? So Fragile X is one thing. You can have an antibody, an autoimmune response against the ovaries or against your glandular functions, against the adrenal glands. So we check something that's an anti-adrenal type of antibody in your blood. We always want to look at your prolactin hormone. We always want to look at your thyroid hormone. But these are the sort of things. We look at your karyotype. We look at your own genes, because people with chromosomal abnormalities can have this problem happening as well. But both of these women had otherwise unexplained premature ovarian failure, and both of them, and they were on hormone replacement therapy, the whole 9 yards. Both of them, through the course of later, I knew them for years. Both of them ended up, of these two that I'm thinking of, ended up getting pregnant spontaneously and surprisingly pregnant, which shocked everybody because it was not anything anybody was anticipating or expecting to happen. So yeah, it can happen. It's unpredictable, and it's not really something that we have a lot of control over. That is to say, the ability to sort of help you with that. There are some experimental therapies that we have now, as I said, with rapamycin, but a very interesting phenomenon. And of those two people that I'm thinking of, I still know, dozens and dozens more whose ovaries didn't behave in that way, and they did not have those spontaneous pregnancies. But people can actually, as I say, sort of flip in and out of that premature ovarian failure. We've got Lelix here tonight. We've got David. Good evening, sir. Hi, Kowser. Nice to see you. Hey, Megan. Lisa in US, nice to see you. And Haley, thanks for being here. Elena has joined us over on the My Instagram side there. Bunch more people on Facebook, and it looks like YouTube as well, along with LinkedIn. And we've got New Life's Instagram right here. Hey, if you've got questions tonight about things about fertility and women's health, throw them my way, because that's what we're here to talk about. I got a question here from looks like Gallivance. Gallivance says, what is the cause of my abnormal pap smear, and will that keep me from getting pregnant? And that's a great question. So a pap smear is a screening test for pre-cancers of the cervix. We have been very effective at, I won't say eliminating cervical cancer, because it still very much is something that happens, but the number of cases in the United States, for example, the last I checked the number of new cases were less than about 3,000 per year, which is really excellent. We've done a great job at stamping out cervical cancer because we've gotten so good at screening for cervical cancer. And that's the pap smear. Now, nobody likes a pap smear, right? Nobody likes a pap smear. It's something that you really wish that you didn't have to do, but doing it is a very smart thing. And what a pap smear is doing is that it's using a little brush to sample some cells from the opening of the uterus, which is the cervix. Those cells now, typically pap smears are done through a liquid-based test, a liquid-based pap smear. It used to be that they were kind of smeared onto a little glass slide, and literally somebody would look under the microscope at every one of those slides. You would spray some hairspray, actually Aquanet. You would spray Aquanet onto the slides as a fixative, and then it would go and someone would physically look at every slide. Well, what happens now is that the pap smear, the cells are collected from the cervix, and then it goes into some liquid. And in that liquid, it's ultimately processed by a machine. And what that machine does is that it's able to clean off those cells so that they're easier seen. It gets rid of some of the other junk that's there, some white blood cells, some sloughed off skin cells from the vagina. And that's really what makes up the majority of vaginal discharge. It's those sloughed off skin cells from the vagina, the squamous epithelial cells. Then usually a machine will start by reading the pap smear, and then it is most often followed up with what's called a cytotechnologist, and that's someone who will go and actually look at the slides and verify. They'll do a sampling of those ones that are read out as normal and the ones that are read as abnormal. Then they will usually look at them and confirm that they are indeed abnormal. So what you're looking for in that pap smear is the potential for precancerous type cells. And those cells come really just from one thing, by and large, and that is the HPV virus, the human papilloma virus, which is a sexually transmitted virus that almost everyone will have been exposed to at some point during their lives. They say that about 85% of us have been exposed to HPV at some point by the time we turn 50. The risk factor is having more than one sexual partner in your lifetime, or being with someone who has had more than one sexual partner in their lifetime. And nowadays, that really counts for about everybody. The HPV virus, I describe it as the common cold of the vagina. Because in most people, like any other common cold, it comes along, you catch it, eventually your immune system recognizes that it's not supposed to be there, and ultimately you clear it. It goes away. But in some people, the HPV virus can stay, that the body is not able to clear it, and that's thought to be one of the mechanisms by which those cells can turn into cervical cancer. But cervical cancer always begins as a precancer, and that's what we're testing for with the pap smear. So when you have a pap smear, it comes back as really usually one of three different findings. It's either a high grade change, which is kind of high up on the ladder. It is a low grade change, which is lower on the ladder, or something that's called atypical. And atypical is sort of one half step away from normal. It's not quite normal. It's not quite abnormal. So when the pap comes back as atypical, they run the test specifically for the HPV virus. If the test comes back with low grade or high grade, the presumption is this is HPV caused, and so testing for the HPV virus is not necessary, really only when it is an atypical pap smear. So if the pap smear is atypical, that is not quite normal, but not quite abnormal, and the HPV is negative, the presumption is, this is probably really one of those lab findings that really probably it's not something that is legitimately going to be a problem. So in that scenario, you can really just repeat that pap smear in a year. But if you have an atypical pap smear with a positive HPV, or you have a low grade, or you have a high grade, the next step is a procedure that's called a colposcopy. Colposcopy is basically, it's like a pair of binoculars on a little stand. Put some vinegar on a Q-tip and put that Q-tip onto the cervix, which causes cells that are abnormal to take on a different appearance. And that appearance we can see by looking through this microscope at the cervix. When we see those cells that are abnormal, we can take a sampling of those cells. And those, the result from that will come back really with one of four different findings. It's either normal, so bottom of the ladder, normal finding, or it's a level 1, a level 2, or a level 3 as you climb up that ladder. Level 1, 2, or 3, it stands really for mild, moderate, or severe, and the term we use for that is dysplasia. Dysplasia means pre-cancer. If you have a level 1 dysplasia or mild dysplasia, we know that the majority of those will just clear on their own. They will go away by themselves. And so really you don't have to do anything about that. In the olden days, we used to do this thing called cryotherapy. A cryotherapy was a treatment, a freezing treatment on those cells in the cervix in order to try to get rid of those abnormal cells. You don't want a precancer on your cervix, do you? No, certainly not. So therefore, you would do a cryo. Well, now we know you really don't have to do that because those will in all probability just disappear. The point of the whole exercise is to see who has a level 2 or a level 3, because those are what we call high-grade changes, and those are more associated with the risk for potentially becoming cervical cancer. And so in that scenario, you do what's called a cone biopsy, or sometimes called a LEAP procedure, which removes those abnormal cells from the cervix. And when those cells are gone, in most cases, the problem is solved. So the question is, does HPV cause problems with pregnancy? And the answer is no, it is not a cause of infertility. Now, that said, if you have the burden of HPV-related disease in the cervix, and let's say you had a high-grade cervical dysplasia for which your doctor felt the need to remove those abnormal cells, they can be taking off, a piece of your cervix, and that piece of the cervix, well, we need that cervix for something. It's better to be rid of that high-grade precancer, but potentially that can have an effect on keeping a baby inside. That can have an effect on how the cervical mucus is produced. Is it now becoming more hostile to sperm? Potentially. So there is no direct correlation between the abnormal pap smear and infertility. There is nothing that says HPV is associated with infertility. But because people can have problems with their cervixes, the cervix can start to cause you problems with fertility later on. So kind of really an indirect sort of finding there, if you know what I mean. It's indirect. Now, HPV is also the virus that causes warts, what they used to call venereal warts, but now also known as genital warts. And those are little viral growths of the skin, classically on the genitals. HPV happens to be the same virus that causes, warts on the hand. It causes plantar warts on the feet, something that many people get. That is still the HPV virus, but it's not the sexually transmitted type of virus. So the one that causes genital warts is typically not the type that causes these precancers, fortunately, and it's usually more of a cosmetic and a self-esteem type of concern as a sexually transmitted infection than it is, really truly a medical issue, unless there gets to be a ton of, unless sometimes there can be a lot of these warts and they can cause, problems just by the fact that there are so many. That HPV infection can also be associated with precancers of the genital skin and also of the anus. And so in that regard, HPV, can create issues for you. It does. But as I said, I describe it as the common cold of the vagina because in most people, fortunately, it does clear. And I will say again that most of us at some point will have some exposure to HPV. A special shout out this evening to my friend Lisa in St. Louis. Good evening. Thank you for being here on the MCRM Facebook side. Shada, hello, my friend, and I hope you're recovered better this week from your big surgery, which I think was just last week. Let's see. We've got a bunch of folks joined in here and I didn't see. So we've got Megan here. We've got E. Winnick. Hello there. Hi, Kisa. It looks like that says my friend Angela Fox. Hello. Zenny is here in South Florida who says, good afternoon, Dr. Fink, and nice haircut. I got a couple of them cut here, actually. They were running a special. Buy one, get the rest the same price, So yeah, I got a haircut. It was about time. I felt like I looked like a clown. I told you last week I was having a bad hair day. Let's see. We've got, it looks like Ildi, I think, is here. Hey, Bailey. Bailey, I just saw today, and actually, Bailey, I didn't realize that you had a doodle because I saw your Instagram post and I said doodles rock. And so do you. And our fingers are totally crossed for you guys tonight, my friend. Totally crossed. Hey, Audrey and Raj. We've got Logan, the therapist from Northwest Arkansas, here this evening. Hello, my friend. And Mariel is here. So I got a question here, it looks like from Megan. Megan says 2 questions and would love your thoughts on either. We have 2 vials of donor sperm that have been thawed and refrozen. Honest thoughts on using those versus purchasing a new vial. So sperm, when you have eggs, for instance, let's say that we're banking eggs and we retrieve eggs from the ovaries and we freeze those eggs and we go to thaw those eggs. Those eggs are really very, very, they're very delicate. They're very delicate. So there is an expected loss rate in those eggs when you go to thaw them and try to use them. Similar that happens with sperm, but when you have one egg is one single cell. And true, one sperm is one single cell, and it's really it's a packet of DNA with a motor on it. You like the visual? I like that visual. Oh, there goes the motor. There goes that packet of DNA. Yes, when you freeze sperm and you thaw sperm, you will end up losing some of that sperm. In fact, there are, you may lose half that sperm when you freeze it and thaw it. You can freeze it again. And when you freeze it again and then thaw it, you are still going to lose even more sperm. So I think, Megan, it depends on what you're doing with that sperm. If you're trying to use that sperm for something like IUI, you may be getting into a range of sperm count that might be lower than is optimum for something like an IUI. And in that scenario, I would say that's probably not the best thing. You might consider getting a fresh vial of sperm. Because think of it this way, when you purchase that sperm from a sperm bank, they're sending you frozen sperm and it has to be thawed in order to be used. So you can absolutely freeze it again and potentially use it again. What a lot of labs will do is especially for something like IVF, they'll take a little scraping of that frozen sperm because, again, for IVF, we only need one sperm for each egg. Right? So you don't need millions of sperm. You only need one sperm for each egg. So scraping that sperm and leaving the rest of the vial frozen is something you can absolutely do. But yes, you can still use that sperm. It's not thought necessarily to affect the sperm quality, but it certainly affects the sperm quantity, that each time you thaw, you may lose half of the volume or half of the concentration of the sperm that you have in that vial. So that is a thing. But as far as sperm quality, you can often look at that sperm and say, well, this sperm looks normal. This sperm is swimming normal. It has a normal progression appearance to it. So, yep, that's a good sperm. We're going to take that sperm and we're going to put it inside an egg. So if you're using it for IVF, I think that you are in probably pretty good shape there. But if you were thinking about using it for something like IUI, just know you're getting diminishing returns every time that vial of sperm is thawed. Let's see, and then considering a third go of IVF, Megan says, just miscarried our second pregnancy. I am so sorry to hear that. Second miscarriage after 5 transferred, and have had my tubes removed, endometriosis removed last year, and confirmed antiphospholipid syndrome. 39 years old. What tests should I get going before restarting? So you got a lot of things going on there, my friend. So a couple of miscarriages, you've had a lot of transfers, you've got endometriosis, and you have the antiphospholipid syndrome. Antiphospholipid syndrome is a situation where in your body you create you create a situation in your blood where that blood wants to create create clots in the small blood vessels that supply things like your placenta. So once we know that that's there, we can treat that. We treat that with Lovenox, right, which is a blood thinner. The endometriosis, given that endometriosis is associated with, gosh, classically it's a pain syndrome. It can cause some scarring in it can change, distort the anatomy. It can also result in diminished ovarian reserve. The thing that we get most concerned about when it comes time for embryo transfer is that endometriosis creates a situation in the uterine lining where you may be opposing your own progesterone levels. Which means that if you're manifesting endometriosis in the endometrium, you can have all the progesterone in the world in your bloodstream, but your body, it's like your body can't hear it. It's like it's sitting there going, I don't hear you, progesterone. And so it doesn't know that progesterone is there. And you need that progesterone for your pregnancy. So certainly I would say, if your endometriosis was removed last year before doing another embryo transfer, I would certainly recommend that you suppress that endometriosis again. And that's with medication, either Lupron or Orilissa, that you typically use for 60 days prior to an embryo transfer. And I think that would make an awful lot of sense. And you may have done that. In fact, my guess is there, Megan, you probably did. As far as a third round of IVF to make embryos, my suggestion is you kind of want to know where your AMH is, and you want to know where your antral follicle count is, because those are the things that give us some prediction as to what sort of response we can expect from stimulating your ovaries. Now, the other thing that we're up against here is the fact that you're 39. Now, 39 is not 45, right? You still have normal eggs in your ovaries, but by 39, most of the eggs that you're going to be producing are going to be not normal eggs. That is to say that the DNA in those eggs has been there for your entire life and has started to become unstable. And as a result of that, when we go to place an egg inside one, or rather a sperm inside one of those eggs, we may find that the egg doesn't fertilize, or if it does fertilize, that it doesn't create an embryo that has the ability to get you pregnant. So let's see. Shada says, not hearing you well, so I'm not sure if there is an issue here with, hopefully everybody can hear me there, but you kind of want, oh, it's better now. Okay, good enough. I think, it's important to know, what your AMH is and where your antral follicle count is, because that's going to give you kind of a realistic picture of how many eggs you can expect. And based on that, based on age, we can sort of extrapolate to figure out, well, what can we hope to get realistically from a cycle of IVF? Because I think that's really very important to know going into the process. It helps for planning purposes, and it helps, I feel, to have realistic expectations in that cycle. So let's see what else we have. Dr. Embryologist, good evening. If you are still there, I'm going to send a wave to say I appreciate you being here. Shada asks, do we need to continue metformin and low-dose naltrexone during suppression for endometriosis to get to a frozen embryo transfer or not? Well, in my opinion, low-dose naltrexone has a beneficial effect when used over time. So the longer you're kind of on low-dose naltrexone, the greater potentially the response that you may get. So I think that that's a good thing. The metformin, if you have a real issue with insulin resistance, that has been proven in your blood. And certainly if you've got polycystic ovaries with proven insulin resistance, then I think being on the metformin may also be helpful to you. But metformin, I would say less so under most circumstances. But I would err on the side of staying on the low-dose naltrexone for sure. And, to be honest with you, if you're tolerating the metformin, I wouldn't say that you need to stop it there either, because it is going to have some benefit to your body. Interestingly enough, in the anti-aging community, metformin is considered a life hack. Because we all have some degree of insulin resistance, and taking a metformin a day is said to potentially prolong our lives. So there might be a reason, Shada, to stay on it. But I don't remember exactly the extent to which you were insulin resistant. But hey, if you're doing okay with it, I'd say stay on it. The problem, with metformin, it's hard to take. It messes with your stomach. Bloating, gassy diarrhea, can kind of be a real thing when you're on metformin. And so sometimes we'll use myo-inositol as a supplement. Instead, it's a little better tolerated. But I like metformin, particularly if you really do have good serological evidence in your blood of the insulin resistance, and particularly in glucose intolerance as well, then I like to use the medication to treat it when we can. Hey, it's 1:15 the top of the hour, and I just blew right by the bottom of the hour, which is typically when we do the 5:30 Fuzzies with Fink. And so I do want to take a moment to do that here, even though it's a few minutes late. So I hope you will please forgive me on that one. The Fuzzies with Fink is what we do to take a moment, it's almost like taking a mindful moment, but to be able to share a little bit of the good vibes we have out there, because this fertility business is a tough one to go through. It's tough emotionally, it's tough financially, it's tough romantically in our relationships. It hurts our self-esteem and our very definitions of self, of who we are. So it can become a very lonely and frightening place to be. And being alone is kind of wired to the core. We're social beings. Some people are introverted, some people are extroverted, but being alone is something that is inherently fearful. It creates fear to us, for most of us. And so feeling alone can make matters even feel so much worse, and make us feel far more remote from the real definition of who we are. So as we're dealing with these fertility concerns, I really would ask each and every one of you to send out some good vibes to all those people out there tonight who really need to know that they're not alone. And honestly, it's not just in the fertility world. It's folks who are struggling at work. It's folks who are struggling at home with relationships and with family. People who are struggling with school or things in the neighborhood. All those stresses that life throws our way that make us feel anxious, that make us feel frightened or depressed, things that make us feel truly isolated and alone. It's just very helpful to know that someone is out there who cares. This is the time that we can stand together as a community and send out all the warm, positive wishes to people out there who are going through a hard time tonight, who need to know they're not alone. I always say, let's break the internet with kindness. If we can't do that, because I really don't know how to quantify such a thing, maybe tomorrow, if you would just take a moment and do something nice for a stranger, an extra kind word to someone who may or may not need it, a smile at someone who you don't know, whatever it takes, It's those little things in this life that make our world a better place. So let's all be a part of that, can we? The world is not a kind enough place. Let's share a little bit of our kindness. Send it out by internet tonight. Positive wishes to everyone who needs it. Know that you're not alone. And tomorrow, how about doing a little something? Just one little, doesn't have to be major, random act of kindness, because that's how our world can change. And that, my friend, is the 5:45 Fuzzies with Fink. Well, we're here to the top of the hour. We got a few more minutes for questions. If you have anything, throw them my way. Does endometriosis cause egg quality problems? Kelly asks. Well, that's a complicated question for which there may not be a super clear answer. Now, we know that endometriosis can affect ovarian reserve. In fact, we believe that folks who have an in some people who have an unexpectedly low ovarian reserve, there may be an issue with endometriosis. So that said, certainly if you have surgery on an ovary to remove some endometriosis, we can expect that that AMH level is going to go down. It absolutely will. But is it doing something fundamentally at the level of the DNA, which is what I call egg quality? And I would say that's a harder one to answer, because most of us consider egg quality in most cases to be really dynamically a function of age. That if you're 24, I expect that 8 out of 10 of your eggs are going to be chromosomally normal. And I expect if you're, let's say, 35, 5 out of 10 of your eggs are going to be chromosomally normal. That number really comes directly as a result of aging. Now, when you throw in some biochemical factor like endometriosis, it makes all the sense in the world to me that it may have some effect on stability of the DNA in those eggs that are housed in the ovaries. And if not the DNA, then perhaps on how fragile those eggs may be. What happens when we retrieve them and we go to fertilize them? There may be some effect based on endometriosis in that regard, Kelly, and that is a very good question. You get a gold star for asking that question. So, and I hope that answers it there for you. Let's see. Styles Family says, can you take low-dose naltrexone and omnitrope after you do your embryo transfer? So I really like low-dose naltrexone for an embryo transfer, because think of it as it is an anti-inflammatory of sorts. It is modulating the immune system. It's turning up the good parts of the immune system and turning down some of the bad parts of the immune system. So low-dose naltrexone, yes, indeed. I usually will keep people on low-dose naltrexone typically until about 12 weeks, until the first trimester has finished. Now, I know that there are some practices that recommend people stay on their low-dose naltrexone for the entire pregnancy. And I would say there is not good evidence that says that you should do that. I'm not sure that there's necessarily harm unless you're on low-dose naltrexone when it's time to get an epidural, and then that may block the effect of the epidural anesthesia. So I don't think that's a good idea, but certainly through 12 weeks, yes, for sure. The omnitrope, I would say, I don't think you really need it. I think of omnitrope or growth hormone as being something that is very beneficial to egg quality. It has, to me, more to do with stabilizing some age-damaged DNA than it does doing anything necessarily for embryo transfer, and certainly not for early pregnancy. I don't know what the effect is of applying growth hormone to an early pregnancy itself. For a limited period of time, it's probably not that big a deal, but in general, I don't use growth hormone for embryo transfer. If you did, I would certainly suggest that it is stopped at the time of embryo transfer. But low-dose naltrexone, yes, definitely I would. Let's see. Kauser says, I'm in my 2-week wait after ovulation. I don't have any pregnancy symptoms, and my vagina is dry with no mucus. Is this normal? Can I still be pregnant? And the answer is, oh yeah, oh yeah. And one more time, oh yeah. So in that 2-week wait, you're really not making very much pregnancy hormone or anything that is truly going to make a lot of changes in your body. Now, many people will have the very first sign of pregnancy start to show up, kind of right around the time that they are going to expect a period. And more commonly than not, it's breast tenderness. But as far as vaginal discharge, as far as dryness, as far as mucus, I would say that is really not a reliable symptom for pregnancy, and I wouldn't rely on it at all. The other thing I would tell you is that I think it's really important that you keep a positive outlook about this. Because, you're already saying to yourself, and this is human nature, I understand it, well, I'm not having any symptoms, so it probably isn't going to work, and I'm just protecting myself. I'm protecting my heart, my emotions here by saying it's probably not going to work, so therefore I'm going to be less upset if I get my period or if my pregnancy test is negative. And yes, we have to protect ourselves, but at the same time, positive vibes are directly associated with positive betas. And I really, truly, honestly believe that. The number of people I see who feel like their butts have been kicked by the process, who become so negative about everything that they're doing, that it's no wonder that the test may not end up being positive. Their cortisol levels, their stress hormone levels become very high. And I think that has an effect on how we implant pregnancy and whether we can let a pregnancy grow. So to the best of your ability, my friend, keep a positive outlook, knowing there is every chance that you may be pregnant here at the end of this 2 weeks, irrespective of what you may be feeling right now. And that 2-week wait between ovulation and period or pregnancy test, it's a tough one. It is a tough one indeed. But best thoughts to you, my friend, and really all the most positive vibes coming your way. Positive vibes, positive betas. That is my lesson for the day, for sure. Let's see. Angela says, you may have covered this, but couldn't hear you. Do you think metformin should go through the first trimester? So I don't know if maybe there's a problem with the audio here. Not sure what the issue is. I wonder if it has to do with this thing here. I don't know. All right. Well, I hope you can hear me there. Yes. So if you're on metformin, I do recommend that you stay on metformin, because if you have that insulin resistance, particularly associated with PCOS, then that is an independent, thank you, Elena. At least somebody can hear me here. That is an independent risk factor for miscarriage. And so staying on metformin decreases miscarriage risk in that first trimester. That same holds true for myo-inositol for the folks who are taking it. If you're taking myo-inositol over metformin, it's 8 grams a day, or 8,000 milligrams. And that sounds like a lot, but each little capsule is usually 2 grams. So you take 2 capsules in the morning and 2 at night. Now, myo-inositol is also something that comes in the form of a powder that you have to mix with a liquid, and then you have to choke that down. I personally find that hard to do, so I would rather take the capsule, and that's the one I recommend to people. But 2 in the morning, 2 at night, so for a total of 8 grams a day, and that's really the equivalent dose of 1,500 milligrams a day of metformin as it pertains to in the use of PCOS. So yes, Angelina, You want to stay on that for sure. Folks, we are going to run out of time tonight, but as always, it is such a privilege to be here with you every Tuesday evening. And I sure appreciate the fact that you joined, that you had something to say, that you shared your good vibes, and that come tomorrow, you're going to do something nice for a stranger, do something to change our world just a little bit with that kindness. As I am fond of saying, this fertility thing is not the book of your life. It is just a chapter. And what are we here to do? We are here to rewrite it together. Every step forward with love, every step forward with kindness, and truly every step forward with hope, because tomorrow is a new day and it's full of all new adventures. So until next time, from Pensacola, Florida, I'm Dr. Randy Fink. Thanks for being here, and good night.